Blood involvement in cutaneous T-cell lymphoma can occur even at early stages of mycosis fungoides, and by definition in Sézary syndrome. In this video series, I will discuss hypothetical example patient cases where flow cytometry was ordered to assess blood involvement. These examples may be similar to patients you see in your practice. Let's discuss patient 4 to find out why flow cytometry was ordered. Patient 4 is a 50-year-old female. She was initially diagnosed at 5 years ago with stage 1B mycosis fungoides, with patch lesions affecting approximately 25% of body surface area. Flow cytometry showed no blood involvement at the time. There was no other evidence of extracutaneous disease. After initial treatment with skin-directed therapies, she received pegylated interferon and experienced an initial partial response, which subsequently waned. She was then switched to an HDAC inhibitor and again achieved a partial response. She recently developed worsening pruritus and a severe skin infection that required hospitalization and IV antibiotics. Since then, she has continued to experience worsening skin lesions, now affecting over 30% of body surface area, with thick plaques and yellow serous exudate, indicative of impetigo and ulcerated tumors, as well as palpable adenopathy. Skin and nasal swab cultures were positive for Staphylococcus aureus, confirming a staph infection. Her complete blood count showed neutrophilia without lymphocytosis. Before we move on, let's consider next steps. This patient had extensive patch stage mycosis fungoides, stage 1B, and has been showing repeated signs of infection with recent hospitalization for staph infection. In this case, I would consider treating with oral antibiotics, diluted bleach bath, and intense topical therapy with emollients and steroid creams. If there is persistence of adenopathy, a lymph node biopsy may be considered. We would also check blood flow cytometry utilizing a T-cell panel to monitor for progression. For consistency, I would send the blood samples to the same flow cytometry lab that performed the previous analysis in order to minimize potential variability due to different methodologies across centers. In this patient's case, what are the clinical flags that would prompt further investigation, including flow cytometry? The severe and recurring staph infections, which prompted concerns that the disease may be progressing and impacting immunity. The worsening patches, plaques, and now tumor lesions with enlarged lymph nodes were all suggestive of disease progression. In closing, keep in mind these clinical considerations and recommendations from experts relevant to this patient. Patients with mycosis fungoides or Sézary syndrome may have impaired immunity and increased risk of infection. Skin infection may be indicative of disease progression. Clinical signs of infection and/or ulceration should be worked up with bacterial cultures. Prompt antibiotic treatment of infection is important in patients with CTCL because, in my experience, bacterial infections can aggravate CTCL. Flow cytometry should be performed when there are clinical signs of progression, such as recurring infections and worsening skin disease. Thank you for watching. I hope this information is useful. For more information, including additional patient cases, explore probeinctcl.com.